In this lecture, I'm going to talk about the delivery of a bespoke training program in brachial plexus reconstruction for a resource-limited country, our experience in Cambodia. It's a design and developmental project that we have conducted since 2013. My name is Vaikuntan Rajaratnam. I'm a hand surgeon, a medical educator, and an instructional designer practicing in Singapore.
Cambodia has a population of close to 17 million and 50% of whom are under 22 years old. Motorcycle remains the main mode of transport, but Cambodia has a reputation of holding the largest causes of death due to motorcycles in Southeast Asia. Motorcycle accidents are the main cause of brachial plexus injuries in developing countries. The impact of brachial plexus injury are very significant due not only to the paralysis of the upper limb with physical limitation, but the severe psychological stress secondary to the flail upper limb and pain, social discrimination due to a paralyzed limb, and economic hardship. These young patients who are usually affected, especially in Cambodia, resulting in the inability to return to gainful employment and work, produces significant impact in the community. The flail upper limb results in a useless limb and becoming a nuisance, which tends to produce a need for amputation of the limb with the fusion of the shoulder to allow them to use one arm to continue with the activities. 5 billion people in the world have no access to optimal surgical care. One of these solutions that has been proposed in a Lancet paper has been surgical volunteerism, which needs to be free-willed with no material reward by the surgeons involved in the provision of service, and it is rooted on the desire to be altruistic, which is a characteristic of the professional nature of a surgeon. It requires a commitment and dedication for long term. In 2013, a team of surgeons from the United Kingdom and Singapore designed and developed a program for hand surgery training in Cambodia. The model was based on the concept of surgical volunteerism, and the foundation was based on the identification of local surgeons who were committed in the training, and then to use an evidence-based approach towards designing and developing a curriculum with specific and targeted skills acquisition program with the support of the faculty from the international community. This was further enabled by the use of technology and has resulted in very satisfactory transfer of skills to the local surgeons, and this has been published in our. In designing the training program from ham surgery, an instructional model of using the ADDIE or IDE model was used. A curriculum was designed based on the needs of the community using evidence-based approach on the various types of procedures that were done locally, and then developing a personalized training program based on knowledge and skills supported with feedback and deliberate practice under direct supervision from the international faculty, and then producing assessment tools based on direct observation of procedures while being supervised by the faculty. The program was then evaluated based on the stakeholders to produce an evidence approach to the effectiveness of the program. In designing the curriculum, there was need to discern the needs of the community, and this was performed by the visiting surgeon in the initial phase of their project by visiting the center and looking at the learning needs both from the community and doing a Pareto analysis of the commonly procedures performed at the center. This allowed for the development of a targeted training program that is based on competency and identification of the skills that were required to be able to produce competent surgeons to practice independently. Assessments were then designed based on the practice of the individual surgeons at their workplace. In order to evaluate the program of surgical training, at the end of 3 years, we performed an assessment of the identified surgeons on their level of confidence before, after, and of the future. The objectives of this training was to ensure that the surgeons who were trained were able to teach others to allow for capacity building. And as you can see that we were successful in increasing the confidence level to perform independently. The detailed personalized programs, and this shows the methodology used to deliver the program. For the assessment of brachial plexus injury, we use case-based discussion to develop higher order thinking, especially decision making and planning for surgical management. Surgical option generations were done through lectures and case-based discussions. The selection and execution of the procedures were done under supervision, with direct observation of procedures being done by the faculty until a level of competency was achieved, following which independent practice was allowed with the visiting surgeon unscrubbed. Deliberate practice and feedback was provided through the use of technology when the surgeons had returned to their original countries, through the use of videos and WhatsApp messaging to provide the scaffolding required to support these surgeons. Independent performance and assessment were performed through work-based assessment, especially the use of direct observation of procedures. The support of the local hospitals and stakeholders was crucial in delivering this program, and one of the important skill acquisitions for brachial plexus was the microneural workshop, which was conducted very early on in the project, and the use of the facilities locally, especially with the use of 12 microscopes, allowed for the capacity building of surgeons. The recruitment of surgeons who were committed to do microneural repair were done through a competition to see how they had the ability of fine motor skills. A standardized program was used with low cost, high fidelity biological models using the Trotter's nerves in the pig model was used. Based on the needs and available local resources, this was the reconstructive strategy that was developed initially for the local surgeons to be able to practice. In pan plexus injury with complete flail upper limb, for shoulder abduction, spinal accessory nerve to suprascapular nerve transfer was used, and the participants were trained in this. For elbow flexion, phrenic nerve with the use of pseudo nerve graft to the branch of the biceps was used. Long phrenic nerves were attempted as harvested from the phrenic nerve from the diaphragm and then transferred to the biceps. However, the results were not encouraging and has been abandoned. For hand sensation and an attempt at finger flexion, contralateral